All right, well, hello everyone. Welcome to ICE 2025. Great place. The weather's not quite been cooperative, but hopefully it'll pick up a little bit. So basically, a little premise behind this is it's kind of for people that have been in the business for a while. Say you started off maybe like an ultrasound or like say gen rad, and to be honest, I'm working on the same stuff every day all the time kind of gets boring. So maybe you're thinking about maybe changing things up a little bit, or saying, you know what, I've got what I've been doing down and I feel pretty confident, and maybe I need to kind of change things up. So let's get started. And my name's Brian Wilson. I'm a certified biomed and radiology person. Been in imaging for not quite 20 years. I also spent a stint as a biomed almost 20 years as well. So kind of been around the block a couple times. I currently work for Avante as a field service engineer. Where to begin? So, like I said, with the premise that you're probably here saying, I'm confident and comfortable with what I've been doing for a while, and maybe I need to change things up, maybe change my modalities that I'm working on, or even kind of move into some of the related areas to servicing imaging equipment. So I guess the first area that you could probably look into, if you're sitting down planning, like, well, where's my next step, or what's my next step? And education would be a good start. Every situation's kind of unique in terms of where you work, what role you are. You may have someone in your department that's getting ready to retire, and they're going to need, that to fill that position. That might be your chance to jump in and move in a different direction, or maybe you've added new services, or added new modalities that need support. So one of your first steps would probably be to look at education. Some of those options, of course, are the OEM and their service training. Have some excellent other choices. You have like RSTI, you have All Parts, you even have Avante. We do service schools on different modalities. So, that might be part of your plan. It's a good way to kind of introduce your thoughts and your desires to maybe move into a different area with like your manager, and say, hey, you know what, our CT guy's, getting ready to retire, and I think I'd really like to get into CT, and here's some, excellent classes on CT, and that kind of gets your foot in the door, gives you a placeholder with your manager, or who you might have to report to get that certification. So certification with imaging seems to be kind of a mixed bag. The biomeds are really big into certification. That's kind of a given if you want to move into the more senior positions with the biomed field. A lot of organizations require that you have to have certification. Imaging, not so much. I think it's more of an in-house type of process. The manufacturers, I worked for GE for a stint, and they could care less about certification. As a matter of fact, a lot of them don't even know what certification is. I would have to disagree with that. I'm not saying that a person can't move on and advance themselves without a certification, but depending on your organization and the situation that you're in, I think certification is also a good way to help advance your current situation. Say, like I said, you're doing gen rad or ultrasound and you want to work on some of the big time modalities. Getting certified kind of shows your employer that, yeah, hey, I'm invested in this. The certification also covers all the modalities. so that it kind of forces you to learn ones that you may not be familiar with. And it might actually give you a little insight and say, hey, you know what, I had to study for that on the test, and that looks like kind of an interesting thing, say like MRI or nuke med. You might say, wow, I didn't really know anything about that. And so like I said, for advancing your certification, definitely in biomed, that's a must. And I would tend to believe that if kind of help advance yourself, or at least give yourself a piece of paper to say, look, I've gone through this, I've passed it, and I'm ready for my next jump in my imaging career. So one of the things we'll cover will be first modality specific, and we'll cover some of the different modalities that you know, give you a chance to kind of branch out, and then we'll cover again like some of the like related non-modality specific type advancements. So mammo, you know, most people kind of consider mammography as just an extension of GenRad. And yes and no. You know, the technology in mammography isn't very much different than what you would deal with in GenRad. It's fairly straightforward. However, with all the MQSA and regulatory stuff that's related to mammography, it is kind of its own little niche specialty. I know in Colorado we have to be actually licensed to work on mammo equipment, so it's both kind of a niche and also regulatory area. To me, mammo is for people that may be a little more detailed oriented with the regulations and stuff, and the machine's very fine and precise. So if you're kind of one of those people that like really get into the details and really want to make sure that things are just dialed in just right, mammography might be an option for you to pursue. Again, mammography, there's really nothing outstanding about it as far as the makeup of the machine. It's got a generator, just like any other GenRad system. Got a console, again, just like a GenRad system. And the gantry and the C-arm stand is a little bit different than some of the GenRad systems you work on, but not too far out. Another thing that mammography's got that's kind of a little different than some of the GenRad systems you might work on would be the tomography portion of it on some of the newer machines. And I'm old enough that I can go back that I remember the old linear tomography systems and have worked on them. So this isn't anything new, but if you're more recent into the field, tomography is kind of a neat little twist to the equation. Nuclear medicine. So here's another one. Doesn't get a lot of attention, but would be a good, I don't know, get your foot into something different, especially if you've been doing just traditional radiology for a while. For me, I can't myself see myself doing nuclear medicine. I've worked with it before, and I've done like first call on it. I had a friend of mine that he was a nuke med guy, and this is kind of like for the Bob Ross personalities of the world. If you want something that's a much slower pace, much more laid back, you don't want to get those crazy phone calls, oh, our room's down, and it's the end of the world. Nuke med might be your avenue to go pursue. So with the nuclear medicine machines, if you're not familiar with them, basically the source is the patient. The patient's given a radioactive isotope, and then these guys up here, these are called gamma cameras. The gamma cameras then scan around. This is a SPECT system, and it's used mostly for cardiac. And so the cameras move back and forth, and then they measure the movement of the isotopes through the coronary arteries and the heart. As far as working on this, it's really, like I said, I would work with my friend Marshall, and he'd be like, hey, I need to go do a calibration on one of my machines. And so I'd go down there with him, and he'd go get a pig, and which is what the isotopes are kept in, and he'd go flood the array and set the calibration, and then he'd be like, yeah, you want to go to lunch? I don't have to be back for like 4 hours. And I'm like, what do you mean you don't have to be back for 4 hours? What kind of calibration is that? And he goes, hey, that's just how it works. So like I said, if you're looking for maybe a little slower pace or a little more sanity, as opposed to some of the crazy, like calls you might get, Nuke Med might be a good way to, kind of slow down and enjoy life a little bit rather than running around some days. And here's another, I believe this is a SPECT. Well, it's a SPECT. Well, in any case, like I said, I'm not super familiar with nuclear medicine, so I can't address it firsthand. Other than the people that I see that work in it, I had another coworker. I was trying to guide him into vascular, and he told me I was crazy, and he went into Nuke Med. So he seems to really enjoy it. Now, another part of Nuke Med is PET CT, and this might be for the people that are a little more want a little more going on than your typical nuke system. So up here is basically a regular CT scanner, and then back here is your PET portion of the machine. And so what they do is they introduce the isotope to the patient. They do a CT scan, which helps them get the actual, I guess you want to say, the roadmap or the landscape of the patient anatomy. And then they move them back into the PET, the more traditional nuke med system. And then it's able then to track the isotopes if they're doing some kind of like a bile duct study or a cardiac study. Or brain. So between the two technologies, they're able to get a more accurate idea. If anyone that's seen like nuke images, to me, they're about as clear as mud. This is just me coming from an X-ray vantage point. But with the CT images laid over the top of them, they make sense. Oh, okay, when we're looking at the common bile duct, and these are the isotopes go down the bile duct looking for an obstruction. Myself, I've only worked on the actual CT portion of the machine. I know nothing about the actual back end of the system. So, if it was a CT issue, no problem. I could take care of that. When it got beyond that, then I would have to call one of my more matter or subject specific individuals to take a look at it. I have taken the backs of these off, and they are pretty cool to look inside, and it would be an interesting technology to learn more about down the road. But like I said, I'm just kind of a straight CT guy, so didn't go beyond that. Vascular. So this is kind of my, I guess, forte in life. I started off working on cath labs. That was my first modality. A lot of people in the business that I've talked to really have an issue with working with vascular. I haven't quite figured it out. The technology on it's nothing all that, I don't know, you want to call earth shaking. It's just basically a big C-arm that's either planted to the floor or to the ceiling, and you've got a fixed table. And I think a lot of it, when I was in biomed, I did anesthesia, so I worked a lot in the OR. And so working in that environment wasn't too unusual for me. I think a lot of people have an issue with working around it. If you get like even a CT scanner or an X-ray room go down, normally they've already moved the patient off the table and they're off somewhere else getting their study done. So you walk into the room and you just have a machine. With vascular, often you'll walk in and there'll be a patient on the table and there'll be a lot of people standing around looking at you like, fix this so we can, get our case going. Another thing with vasculars, you normally have a real high acuity level patient. You might have someone having a heart attack or a stroke. I know that adds another magnitude of layer of kind of drama and stress. So I guess that's why people have an issue with it. I find it fascinating. I love working in the cath labs and the IRs. Always learn something new. Talk to the techs and kind of pick their brains as to what's going on or what they're doing. And the advancements in technology in the past 20 years that I've seen in the cath lab is just fascinating. That my grandpa had a heart attack back in the 70s and it was basically change your diet and get bed rest. That's all they could do. And I would say probably 80–85% of the patients that come into the cath lab, I mean, they're having the worst day of their life, and on death's doorstep, and within an hour and a half, they're talking, they're smiling, they feel so much better, and then they have a good outcome. And I guess in a small part of that, I feel I have a contribution by keeping the machine running and for that technology to be available. And yeah, it is dramatic. You get people, you get the cardiologists in the cath lab, and you get the radiologist in IR, and they can be a demanding lot. And I guess you have to have the right personality to kind of deal with that. So it's a little more fun and exciting than nuke med, in my opinion. So here again, like I said, here's a biplane system. You got your frontal C-arm and it's planted to the floor, and then you got your lateral system that's hanging off the ceiling in the back. This is one of their like primary stroke rooms. Then here's just a good old-fashioned cath lab. You got your just one plane mounted to the floor. You got your table and your controls, and you got your equipment room here in the back. Like I said, it can be a stressful environment at times. I like to think of these as kind of like a fine sports car. If you like to tinker with something that's got to be just dead on, and you like, having a, I don't know, like I said, it's just kind of a fine-tuned machine. They can be a handful when they do break. But at the same time, when they do work, they work really well, and what they do with them is really amazing in my book. So both on a technology and on a clinical end of things, these are really cool systems. And don't let the procedures in them necessarily scare you away from the opportunity to work with the technology and some of the other benefits. Now, this is a bad day in interventional radiology. So I got a call Monday morning from the lead IR tech, said, hey, we're having some problems with our room. I was only like 20 minutes from there. I said, yep, I'm on my way, I'll be there. So what happened, this was like in March, and we'd gotten a really heavy snow, and their IRs were in the older part of the building. Well, part of the roof failed because of the weight of the snow, and all the runoff on the weekend then came into the IR lab. Well, they had left the room on, and so maintenance and housekeeping had came in during the weekend to clean the mess up. So at least I didn't have a bunch of water to deal with, but basically flooded the whole lab, including the equipment room. So this isn't one of my better days, and hopefully you don't have too many of those. Interestingly enough, they were able to repair the system, and it's still in use. But yeah, so some of the, any modality would suffer from this, but this is kind of a fun picture. This hospital, for whatever reason, had something, the water gods must have hated them. They had 2 other labs get flooded over the time I took care of them. They had the IR lab next to this one, and I would like to talk to the facility person as to why they only fixed that one portion of the roof above this room, because the room right next to it, the next year had the same thing happen. It snowed, the roof failed, and then the water came in on it. I don't know, I guess if I'm fixing a roof, I think I'd fix the whole roof, not just part of it, especially if you have, you know, this kind of technology directly under it. The other one was a real unfortunate moment. The machine was not even 6 months old. It was in the cath lab, and again, housekeeper came in. She had some kind of cleaning device, and the sprinkler head was like literally up here. And she was cleaning the wall, and she knocked the sprinkler head off. And it was on a weekend again, and she took off and ran. She didn't report it to anyone, didn't say anything. So that lab was getting just drenched for who knows how long. The only reason anyone noticed there was a problem was the floor below, the water started coming through the ceiling and getting them wet. And they sent someone up to investigate where the water was coming from and found the cath lab was, that one was a forklift upgrade. It was only 6 months old, and they had to tear the whole room out and replace it. So that was an insurance thing. But yeah, like I said, this hospital, for whatever reason, had lots of water issues with their equipment. And another aspect of vascular, which is really cool, and actually this is probably one of my favorite parts of working on vascular systems, is your hybrid ORs. And so basically a hybrid OR allows you to do the same kind of procedures you would in a cath lab or an IR, but you do it in an operating environment, which gives the advantage, say if they're doing like a TAVR or some kind of internal replacement on the heart, and they run into problems, then it's basically set up as a CVOR, and it has perfusion machine, has the anesthesia, has everything you need in that room, so that you can go from a non-invasive procedure to an invasive procedure. And like I said, with my anesthesia background, I'm like a duck in water working around these hybrid rooms. So I enjoy this. This particular room I really like. It's a robotic room. And so basically back here is a auto industry level robot. And then you've got the traditional C-arm hooked up to this. This room can actually pick itself up, the C-arm, and you can do like a lateral scan across the whole table, or you could do like around the table type scans with it. This thing can do a 360-degree scan, so you can do 3D with it. Super cool system. And like I said, for me, the technology alone, working on this type of stuff is really neat. I've never worked on the robot. I'll just say that they got to call someone from actually almost out of country to come over and actually work on the robot. Fortunately, I think I've only seen one maybe break once or twice. So it's not a real common event, but as far as the rest of it, and even driving this thing in and of itself is really a fun thing to do. So if you're really looking for kind of cutting edge technology and want a little excitement, sometimes too much excitement, vascular might be an avenue to look at to move out of, say, like GenRad or ultrasound. CT. So for me, this was my moment where I had my career advanced for me. Despite best laid plans and thinking, well, I've got this laid out and this is how I'm going to see my career, play out and do all that. So over the years, I'd been doing cath lab and IR, and I was quite happy doing it, and had offers from my manager to say, hey, how would you like to switch over and change your game up and go into CT MR? Didn't want anything to do with it, absolutely not. And so they're very good about it. I was very gracious. I said, thank you for the offer, and I appreciate it, but I just don't see myself doing CT. And so that happened a couple times. So lo and behold, the pandemic shows up. And anyone that's been in the business since the pandemic knows how much the pandemic just kind of wrecked things for everyone. Well, we had a guy that was working doing CTMR. I worked for Trimedics at the time, and we had a team in Denver. So we had CTMR team, and then we had our GenRad team. And guy was 72 years old. I mean, come on, you know, it's like you could retire anytime and call it good, but he just really he enjoyed doing what he did. Well, because of the pandemic, he decided, you know what, maybe it's my time now. I'll just get out of this whole healthcare thing while I'm ahead of the game. Certainly understand why he got out. So the lead tech, which I happen to be friends with for the CTMR team, comes in, and I'm working on a cath lab, and he walks in and he just lets out this just sinister laugh. And I'm like, what? And he just says, you'll find out. And I'm like, oh no, what's going on now? So then a little bit later, my manager called me and said, hey, we've just had to change the plans. Now you're going to do CTMR. And I was not happy. I was not happy. I understand why. I mean, you know, certainly can understand why Bob wanted to get out of the business while he could before the COVID hit and all the issues with it. So I became CTMR guy, much to my chagrins. And I am so glad they did that. My perception of CT was completely 110% off from what it really is. And so that was kind of my moment to advance my career without necessarily asking for it to be advanced. So we'll cover CT here. So like I was saying with the cath labs, vascular systems, they're like a fine-tuned Italian sports car. You know, there's lots of little encoders, and you know, everything has to be just right, you know, and they run like a fine-tuned machine, which I can appreciate. It's kind of fun fixing them and getting them to do what they need to. I'm going to say this, just since I've worked on both sides of the thing, working on a CT scanner is like working on a truck. They're big, they're heavy, they're clunky. It takes a lot of brute force. So my background before I got into biomed and then later imaging was I was a mechanic. I love wrenching on things and busting my knuckles. Well, this was the modality that was calling me that I never knew. I always thought CT scanners were even worse as far as more finicky and hard to work on than a cath lab. And come to find out, they're, like I said, it's like working on a Mack truck. So basically CT scanner, you've got the scanner, you've got your table. Just like with any of the modalities you've worked on, it's typically the interfaces on them that get dinged up. It's not the machine. So, you know, the table will get jammed, or they'll put someone on there that's too heavy and they'll, you know, hit some overrides. You know, on the scanner itself, you know, you have your interface and your buttons. They'll get contrast on the Mylar window. They'll get contrast down in the table. They'll get contrast everywhere. So we'll just not even ignore that one. But so most of the calls you get, you just clean some contrast off the window, or you got to replace some, you know, push buttons here, or like I said, you'll get something caught in the table, or they'll run the table into something or something into the table. So really, I would say more than half of your calls are just really dumb, easy to fix operator, you know, just kind of environmental issues. Some things about CT, it was introduced in the early 70s. It was developed by a division of EMI Records, which happened to be funded by the Beatles. So in a roundabout, backhanded way, the Beatles more or less kind of helped get CT developed, even though they weren't directly involved. It was originally known as a CAT scan, which is computed axial tomography. Now it's just CT, which is computed tomography. So this is a bad day in CT. So here's the inner workings of one if you haven't actually seen one. So this is your DAS. This will be where your detector modules are. This is your X-ray tube up here. And then you have, your assorted support things. Like I said, everything on a CT is big and heavy and clunky, and requires to use, I don't know how many wrenches I've broken and sockets I've snapped on these guys working on them over the years. So if you're looking for a more finesse or gentle way of working on something, this isn't your deal. This is breaker bars, big old sockets, torque wrenches, etc. This particular system, we were on our third tube. We were having a lot of issues with it. So, and as you can see, tube's pretty sizable. This is by far isn't the biggest you can get. This is only a 16 slice tube. But if you really like to get in there and work on stuff, and I guess, like I said, just do some wrenching and bust your knuckles, this is the modality to do it. My lead at the time, he was an old diesel mechanic in the Army. So with us both being ex-mechanics, I mean, this was like secondhand for us. So if that's something that you might like to do, I think most people that are in Gen Rad eventually end up here at some point, whether it's by their choice or not. Like I said, for myself, I love working on CT even more than I do cath, even though I've got 15 years more experience working on cath than I do on these guys. I'd rather work on one of them, just, personal preference. Then here's a CT scan. MR, so one of my big problems that I had previous to when I was working with TriMedics, I'd worked at a hospital and I was a one-man shop, so I covered all the modalities. I didn't have a choice. So I had worked on some CT and some MR before I got promoted, doing first call stuff. One of my problems with MR is I would faint in the MR suites, especially if I was close to the bore. So if I was working on, say, the table got jammed or something close to the bore, I'd hit the ground. And even with 3T scanners, I have to be really careful. I can't move real fast in the room on a 3T scanner because I will hit the ground. And so the first time it happened, I was really embarrassed. And the tech comes in and she's like, "Oh, I see you got that problem." And I was like, "Oh, what problem?" She goes, "Yeah, I've got the same thing too." She goes, "It's really embarrassing when you're, getting the patient set up and then you faint and fall over the top of them." So what I found out later, I was working on an MR, happened to be summertime, and I was really dehydrated. And it was just a 1.5 T, and I was working on it, and I really started getting dizzy. And I said, I need to take a break. So I went down to the cafeteria and I grabbed a Gatorade and I chugged it. That was 20 ounces. And I was like, you know what, I'm still thirsty. So I grabbed another one and I chugged it. There's 40 ounces. I grabbed a third one and I chugged about half of that, and I went up to MR and I felt fine. So putting it together, MR uses hydrogen atoms in its scans. So it likes things with lots of hydrogen in it. What's water made out of? H2O, hydrogen with oxygen. So what was affecting me is that I was dehydrated, my hydrogen levels were down, and the magnet was messing with my head. And since then, I always make sure that I'm well hydrated before I go into an MR room, and I haven't had a problem with the fainting since. So my own little personal story with MR, I told my boss when he quote unquote promoted me to that, I said, I do faint in it. And he goes, "Yeah, you'll figure it out." I was like, "Yeah, thanks for the concern." So of course, MR uses magnetism to make its scans. You have a great big magnet in the room, and then you have your, of course, associated. I should have taken some pictures of the other stuff that goes with it, but in any case, there's stuff that goes along with the MR that if you haven't been in one of the rooms. One thing, there is actually a couple hazards that keep in mind if you are looking at getting into an MR career or servicing them. You of course have the magnetism, so you can't have any kind of ferrous tools in there, at least you're not supposed to. Well, we won't discuss that one. And so yeah, you don't want to go in the room with anything with a lot of metal on it, or any metal in, well, any ferrous metal, I should say. The other thing that a lot of people don't keep in mind, and that same tech that caught me lounging on the floor in her MR suite, also would hand me a ball peen hammer made out of brass. And she goes, yeah, you need to carry this whenever you're in the room. And I was like, why do I need a hammer? And she said, okay, look at the door. The door closes from the inside of the room out. And if you were to have a cryo leak in the room, it's going to fill the room up with helium. What's it going to do? It's going to pressurize the door closed. So you're not going to be able to get out. So you're in a room getting full of helium and you can't open the door. So the standard protocol is you take the hammer and you bust the window open that the tech looks through. And then that way that equalizes the pressure the other way, because then the air, like an airplane, will push out from the control room into the room with all the cryo in it. You can breathe because you're getting oxygen, and then also you'll be able to eventually open up the door because the pressure difference will then change so that it'll favor the outside pressure, not the inside pressure. So that is a real thing to keep in mind when you're working around MR, is you have all this cryogenics. Hopefully, if it does quench or if it does have a leak, it's going to go up the chimney and go out of the building. But there is a possibility sometimes that stuff freezes over because of the temperature of the cryo. That is a risk. One thing I do when I work on MR system typically is if it has an anesthesia machine in the room, I put the anesthesia machine between the magnet and the door. That way, in the event that anything were to happen, if something were to come flying in the room while I'm working on it, the anesthesia machine's gonna be the target, not me. So those are just a couple little things that I like to do when I work on that. But yeah, that tech that told me about the self-sealing door from the inside, if that thing quenches or has a cryo leak, you're pretty much done. I mean, it's going to happen so fast that unless you have an exit option. So those are a couple things that you might keep in mind: the magnetism and in the cryogenics, if you do decide to get into MR. And then, like I said, I had my own little personal issues with the dehydration and the machine messing with me. And like I said, once I figured that out, then it hasn't been a problem. But I guess there are a fair amount of people out there, techs included, that do have an issue with the magnetism, especially 3Ts, that they will faint. So kind of one of those little industry hidden secrets. So basically, like I said, it uses magnetism to make the images. Doesn't expose the patient to ionizing radiation, which is an advantage. Can give better resolution on soft tissue than traditional image techniques. And again, MR works on tissues with lots of hydrogen atoms, like your brain has a lot of water in it, or it should. Now, a lot of the areas that we will be responsible for, again, a lot of the stuff that you'll get called in on for MR systems will be interface issues like controls, table all the time. There are a lot of the interface between the magnet and the table will have issues, and then you'll be messing with the doghouse and the little interfaces between the table and the machine. One of the things that a lot of people don't know in regards to the MR is the gradient coils. So when you walk into an MR, you'll hear that banging and thumping and all that weird noise going on. It's actually from the gradient coils, and they're positioned in X, Y, and Z in relation to the magnets. So what happens is, as they're doing their scans, say if they want to do primarily focus on the brain, they can goose the main magnet over to where the head is in the scan, and by doing that, then that's where you'll hear the coils and the gradients start making all their racket and noise. And this basically helps them focus the scan into a particular area of anatomy. And then these little fingerprint things you see on the side here, these little silver things, these are your gradient coils. I didn't know that. I knew they were in the magnet, but this is basically the sleeve over the main core. You can see the big magnet cores here. And these little gradients then kind of goose the magnetic field, the great big one, into a focused part of the scan. Another area that you'll spend a lot of time on, just kind of like with ultrasound probes, is your external coils. And they have different types of coils depending on the anatomy and the type of scan they're doing. And again, that one's for like a arm or a hand. And that's a surface coil that goes over the torso. And what these do is also help enhance the scan, so that as they're doing their scan, then they can concentrate and focus on it. Some scans or some coils are receive only, some are send and receive, so they can actually help the signal. Radiation therapy, so not exactly a modality that we would consider as an imaging modality, but it is kind of a related, I don't know, cousin to medical imaging. They use it to treat cancerous tumors, like a prostate, lungs, head and neck. It's also being used for breast cancer. And so here's your linear accelerator. And then an associated part of that is you have your CT that they use for the planning and treatment. They'll map out where the tumor is, and then do their simulations as to where the LINAC needs to go. My personal observation on guys that have been working like for Varian on the linear accelerators that I had anything to do with, that's like a lifetime job if you want it. I have never heard anybody get laid off work on linear accelerators. I actually looked into the idea of maybe doing that. As for a short stint, I got, I don't know how you want to say, laid off from my biomed position, and I was then turned into a radiation therapy technician. I'll have to say it was probably one of my best jobs I ever did. I did the blocks for the linear accelerator for the collimation. Back in the day, we didn't have the fancy blade collimators that they do now, and so you would have to do your simulations, then build your blocks, then the physicists would check your blocks, and then they'd use those blocks inside the linear accelerator. And super cool job, really liked it. Then I got demoted or got kicked out of that and got sent back to biomed. Boy, I was not happy, but for those 6 months, it was really a cool stint. They just couldn't find anyone to do the blocks. That I guess is kind of a rare talent. So I got repurposed from a biomed to a rad onc tech, and really liked it. But one thing that I've worked on a number of RT machines for the simulations doing CT. So you can be a CT guy and still end up in radiation therapy. Okay, so now we're going to get into some areas that aren't necessarily like turning a wrench or fixing things as you would traditionally think. So of course, when I worked for GE, we had a huge tech support. Trimedics had their own tech support system, and then Avante also has tech support. And so basically what you would be doing is, rather than going out and fixing broken stuff all the time, you would then be helping guys over the phone and also customers to help triage their machines and see if it's something that you even need to send someone out on. This tends to be, kind of like where guys that are done, turning a wrench, or they're, like, yeah, I'm really not into this whole running around like crazy and fixing broken stuff. I'll be a tech support guy, which is kind of cool. If you want to kind of slow down towards the end before you retire and kind of, share your knowledge. This would be a neat, I don't know, area to kind of get into. There are some, like anything, like with, technicians or, tech support guys, there's some guys that are really good. Talk to them, bam, you're up and running. Talk to other guys and you're going like, yeah, my wrench has got more firsthand knowledge than you do. So it's a hit or miss thing, but that might be something, especially, I'll admit, handling those CTs are starting to kind of wear me down. When I work on them, they are big and clunky and heavy, and I'm not quite the 25-year-old that I used to be. So yeah, there are days when I'm thinking, should I even still be doing this? Especially I gotta, bathe in icy hot and take a bunch of Advil after working on one at the end of the day. So this may be a good, like, kind of at the end of one's career option to, have the physical abuse and you can still use your mind. And then field service. So I've been both. Well, actually, I've been in-house and field service. And I'll have to say field service worked best for me at different stages in my life. So I was an in-house guy for quite a few years, had an opportunity to go do field service anesthesia. Really didn't know how I think I would like it, but it worked out really well. And I was young. I was like in my late 20s, and wife and I hadn't made any life commitments or anything yet, so it worked out well. And so I traveled all over and worked on anesthesia machines. And then we decided to start a family. Well, traveling around the country and you got a newborn, that doesn't work real well with the family. So I had to hang up my field service career, and then I went back in-house again, which I spent quite a few years in that. Well, now I'm back in the field again. My daughter's all grown up, and matter of fact, she's working in biomed. So now I'm kind of free to roam about the country again. And it's still fun. It has its pluses and minuses. Getting your flight delayed for 8 hours isn't fun. But the job itself is neat. I get to go to different hospitals, get to work on different machines. So if you're someone that might like a little variety, or like to kind of see the world, field service is a good way to go. I've learned a lot of stuff that I wouldn't have learned when I was in-house. The only thing is that you get to work on other people's mistakes, because typically they'll call us after someone else has worked on it. And again, there's people out there that really know what they're doing and they just ran into a problem. Other people not so good. So it does take a little bit more layers of resolution than say if it was your machine that you've taken care of for years and years, and every nook and cranny of it, and then you come up on someone's basket case. That's kind of a drawback sometimes. But yeah, no, I've been enjoying back in the field again. Wife's glad I'm out of the house. That way if I'm cranky or having a bad day, then she doesn't have to put up with as much of those. So it does work in that regard. Modality specialist. So there's a kind of different definition for modality specialist depending on your organization. So when I was with TriMedics, I worked with this gentleman. He was our vascular modality specialist. His name's George. And George knew cath labs and IR frontwards, backwards, inside out. And we worked together until I got my CT promotion. Boy, he was not happy. And so George, he was kind of, we worked in a regional thing. We covered all of the Denver area. We had like 8 hospitals. And so anytime there was like a serious issue or problem with cath lab, then George was the go-to guy. I had plenty of experience and could do a lot of the same stuff George does, but they always had in their mind that he was the fire department. He put out the fires, which was fine with me because then I could go do the more mundane routine stuff and he could go take on the more challenging calls. But we worked together a lot, and George is a great guy, really knowledgeable. So depending on your organization, we had modality specialists in GE as well, but they were probably more along of a tech support type role. You would call them and then you would work with them, and if things really got bad or if the customer was really having an issue, then they would fly someone like George out to help you get the machine fixed. So depending on the organization, but like if you had like decades of experience working on that particular type of modality, this might be something to look into. We always joke that George spent more time drinking coffee than he did turning a wrench. But at the end of the day, when something really bad went down, he earned his money and his coffee time. So no fault there. Manufacturer. So again, like say maybe you're an in-house guy, you've been doing that for a while, and you want to have a little change in plans. There's a lot of different routes you can go working for the manufacturer. Working for the manufacturer for me meant field service. So I covered like northeastern Colorado. So I had about about like 100-mile radius that I worked in. So I didn't get to hop on planes and fly around like I do now. I had a couple people I worked with that worked for the manufacturer in a different kind of role. One, he was like an engineering technician, and he would do like QA/QC tests on the different like components to make sure that they were good to go out to the customers. And then also if there were any failed components, say like they sent out a bad tube or a bad generator, and then they would send it back, and then he would sit down and bench test them and figure out what the failure was to see if there was a bad component or bad manufacturing process. I had another coworker that I worked with that worked for the manufacturer, and he was an installer. And so he would go out to the sites and he would install the machines and test them and make sure that they were good to go. So just because you work for a manufacturer doesn't mean you would be like doing like field service I did with GE. You could also have in-house roles or even field roles that don't necessarily involve you fixing something. Project planning. So this is probably one of those less likely scenarios, but it's still a possibility. So we were putting in a cath lab. As a matter of fact, that robotic cath lab. And one of the cardiologists insisted he had a guy that could do it for us. And so we brought him in and talked with him a bit, and then he talked to me and he goes, you know what, you really don't need me. You guys have your stuff laid out so nice and organized already. He goes, I'm not going to be able to really do much for you, even though I'd like to make the money. But there are people out there that's what they do based on their experience. He worked on cath labs for like 20 years and had a really good knowledge of how they worked, and could help like accounts that say didn't have people or a real deep clinical engineering department or planning department. He would go out and say, well, you need to put in a trench this big, this far. You need to have your generator and cooler this far. He had all the specs that the customer needed, and then would make a good and successful lab for him. So, I mean, like I said, this maybe not be the most likely course, but maybe if you're looking to get into some kind of a consulting into things based on your knowledge and experience, this could be a avenue for you. And then management. I'm going to make a statement here about management that may be a little controversial, but hear me out. So I've worked in both biomed and in imaging, and have worked with managers that either have biomed experience or imaging experience or both. And I'm going to make the argument that people that come from an imaging background are actually probably better managers. And I'm not necessarily saying it's because of their personality or their skill set. So when I was in biomed, I almost never ever dealt with a director level person. I mean, that was fairly rare. Never talked to physicians, and almost never. I mean, I could probably count on one hand how many times I ever talked to a C-suite person as biomed. And I did that for close to 20 years. As an imaging tech, though, I'm constantly in directors' offices. I mean, almost like daily or multiple times a day. I talk to cardiologists and radiologists all the time. And on a fairly often basis, I do have people from the C-suite coming down, giving me that pep talk that, hey, we're losing revenue. We really need this room up. You know, needless to say about patient care, it's like our revenue's down and we want this CT scanner up and running. So, and then also as a biomed, say if I had to spend $10,000 on a repair, that was a big deal. I mean, I was like $10,000. Oh my word! How am I going to get this approved? As an imaging person, you know, I can't even get a foot switch for a cath lab for under $10,000. I mean, it's just the nature of the business. If you want to pay or play, you got to pay. So what I'm thinking is that if someone that came from an imaging background, or it came from both, from a biomed and imaging background, becomes a manager, they're already equipped to deal with the personalities, the directors, the physicians, and the people from the C-suite. And then they're also kind of more aware of the dynamics of what this means. So, you know, as a biomed, if I lost an anesthesia machine, I mean, I wanted to be timely and get it fixed and get it back in service, but it wasn't the end of the world. If the ERCT goes down, oh yeah, you're going to hear about that and more. And so that's why I'm going to say that someone with an imaging background that's going into management might have some more skills or more awareness of how this stuff works than, say, someone that's been purely in a biomed setting. Not to say that they both can't be good managers, but like I said, I think someone in management might be, I mean, imaging in management might be a little more equipped to deal with the job. I've had a couple coworkers get into management. The one guy, I knew he was going to be a manager from the day I met him. He was just one of those kind of people. He loved the politics. He loved interfacing with management and going to meetings. He was always volunteering to go to meetings. You know, we're like, oh no, I'm too busy. I don't want to do that. And he was like, oh, I'll go be on that committee, or oh, I'll go to that meeting. So I knew he was destined to become a manager, and he seems to be really doing well with it. The other guy I worked with, great technician. The guy really knew his stuff well. I never talked about getting into management, but he was a great people person. I would always bring him with me when I could. When I say I had an angry manager or the situation was really bad, he would go in there and he would just, I mean, he just leveled the room. I mean, everyone was happy, everyone was smiling, we got parts on order, great job, you know, so he was a natural when it came to dealing with people, and he's a manager now and has done really well. So again, that might be an area that, if, you know, fixing stuff, he later told me, which I was shocked. He said, you know, Brian, I really hated fixing stuff. He goes, that was probably the most miserable part of my time ever working, was working on stuff. And I'm going, why'd you get in the business? He goes, well, because that's what they told me to do when I was in the Army, and then when I got to be a civilian. And he goes, the minute I got a chance to be manager, I jumped on it. He goes, I hate turning a wrench. So I thought I about fell over when he told me that. So if that's something that you have leanings or, you know, an ambition to go towards, we do need good managers out there, because us technicians out there can't do our job unless we got someone helping us. And thank you for your time. Any questions? Oh, thank you. Any questions, comments, thoughts?